Hello, everyone. My name is Dr. Shiraz Haider. I'm a neurologist at CHI St. Alexis Health in Bismarck, and I'm also a member of the North Dakota Mission Lifeline Stroke Physician Advisory Committee. Today, we'll be talking about a very important topic, and that's to assess stroke patients in your ER and also have an understanding of what the transfer guidelines are. This talk is specifically meant for critical access hospitals that do not have a CT scanner and also for clinics that do not have a CT scanner because stroke patients can sometimes show up in the clinic or in the ER. And it's very important to screen and triage them in a timely manner because time is of essence when you're dealing with acute stroke. Many studies have shown that up to 3 million brain cells die every minute when stroke is occurring. So you can imagine how every minute is important. Each loss of few minutes could make a difference between a person being able to see or talk or feel. Even simple things like holding a cup or writing may become impossible when brain cells start to die. So let's go over the stroke triage and transfer guidelines. We'll go to the next slide. This is rather too much information on one slide, but don't worry about the small print. This is basically a summary of what North Dakota stroke triage and transfer guidelines are, and these will be mailed to you if you do not have them. You'll be getting them shortly. They need to be put on your ER notice boards and other places where staff can have quick access to them. And we'll go over the details in next slides. So as I mentioned earlier, the North Dakota Stroke Triage and Transfer Guideline is designed for use at clinics and critical access hospitals that do not have a CT scanner. And the importance of having a CT scanner is mainly to differentiate between ischemic and a hemorrhagic stroke, because that's the key element in deciding if patient is a candidate for thrombolytic therapy or not, which we will discuss subsequently. So the first thing is we have all learned about FAST, F-A-S-T, or the Cincinnati Stroke Screen, where F stands for face, A for arm, and S for speech. However, as the previous slide shows, B and E have been added to FAST acronym, so it's become BE FAST or B FAST, where B stands for balance and E stands for eyes. And the reason for adding BE has to do with the FAST acronym, face, arm, and speech really covers the anterior circulation of the brain. And it was realized that with the FAST screen, almost 14 to 15% of patients were missed because they had other symptoms besides the face, arm, and speech. They may have had leg weakness or balance issues or a visual disturbance such as double vision or loss of vision. So in order to capture those 15 or 14% of patients that were being missed by the FAST screen, BFAST or BE-FAST acronym has been created. And our North Dakota Stroke Task Force highly recommends that BFAST stroke assessment tool be used. And that's what this program today is going to help you walk through all the acronyms and how to do the screen. So let's take B for balance. The symptoms will be, patient will complain of unsteadiness, trouble walking, dizziness, loss of balance, and coordination. And the best way to screen for balance issues is to simply have the patient touch their index finger to your index finger and then touch their nose. Simply called a finger nose test. And you do it on both sides, and also have them do a heel to shin test to see if they have any incoordination in their legs. But for heel to shin test, they have to be laying either in bed or the stretcher. And for finger nose finger, they can be either in bed or sitting. And that'll give you an idea if they're unsteady or ataxic, that there's something happening in their posterior circulation. And that's where balance check is important. In eye exam, which is the next slide, the patient symptoms will be more of either double vision, blurred vision, trouble seeing. And when you assess them, you have to look at eye movements, and also you have to make sure that they are able to see in all four quadrants of the visual field by identifying your finger or the hand as it moves in those four quadrants. In the next slide, this is really going over the Cincinnati stroke screen, which is FAST. For face screen, you need to see if they have any droopiness or numbness on one side of the face. And in order to look for any asymmetry, you can ask the patient to smile or show the teeth. I've often find people have trouble smiling because when they're sick and they're scared, and it's hard to make them smile. So you can simply say, please show me your teeth. And when they show their teeth, you can look for asymmetry. And facial droop is an important sign to look for. In the next slide, we'll talk about arm. The patient symptoms will be more of numbness or weakness in one arm or the other. They can have weakness or numbness in the entire half of the body. But since this is pertaining to arm, we'll talk about how to screen for any arm weakness. Have the patient hold their arms straight out with the palms facing upwards, and have the patient close their eyes. If one arm is weaker, it tends to drift. This is what we call a pronator drift. So you're looking for any asymmetry as the arm drifts, and that's an important sign to watch for. In speech, you're going to look for any confusion, trouble speaking, slurred speech, or difficulty understanding. To simply assess their ability to speak fluently, you can ask them to repeat a sentence such as, "You can't teach an old dog new tricks," and see if the patient is slurring their words, or are they using wrong words, or even if they're unable to speak. To look for any understanding or comprehension, you can ask them to do something for you, such as close your eyes or show me your right hand, and see if they can follow your command. So that's important. Under S is looking for any speech difficulty. And T, of course, as you know, is for time is of essence. And at that point, once you've realized with your quick screen and triage that this patient is having stroke symptoms, you need to contact the nearest tertiary hospital to consult with a neurologist regarding appropriate transfer destination. And in most cases, the patient will need to be transferred to the closest stroke-ready hospital. So what is our goal as we are trying to have the patient be transferred? The main goal is to have the EMS unit be available as soon as possible. The door in to door out goal should be less than 30 minutes. So what can you do during that time while you're waiting for the EMS unit to arrive and transport the patient? There are some basic simple things that you typically do anyway, but we'll go over those one more time. First is to obtain vital signs and do them every 15 minutes. Next is to monitor their pulse oximetry and administer oxygen as needed to maintain an O2 saturation of greater than 94%, starting at 2 liters per minute per nasal cannula. Oxygen is not recommended if patient is able to maintain O2 saturation of greater than 94% on room air. Next, you need to assess their blood glucose. Low blood sugars can also mimic stroke symptoms. And if the blood sugar is less than 60, it needs to be treated right away. Number 4, if you can do a neuroassessment such as NIH stroke scale or do fast ED, which I will go over in a minute, that will be very nice. Your receiving facility where you're sending the patient to will be highly appreciative if you have had time and have documented a good neuroassessment. Fast ED really is the same acronym for FAST, but ED has been added here to help the neurologist or the ER physician check if there is a large vessel occlusion. As you know, stroke can occur from small vessel occlusions and large vessel occlusions. What we need to try to do is identify patients who are having stroke from large vessel occlusion, because here we can intervene through the interventional radiologist who can remove the clot. We cannot remove a clot in a small vessel occlusion because those are impossible to reach. But fast ED screen can help identify large vessel occlusion. And if the screen gives us a score of greater than 4, there's a 60% or higher chance of having a large vessel occlusion. But that's not something that you have to worry about if you don't have time, or you can just visit with the neurologist on call and they can guide you through it. But this will have to be a decision made between the referring and the receiving hospitals to decide what is the next step in terms of intervention. So going over the list of what you can do in your ER while waiting for transportation, if you can document the last well-known, LKW as we put it in the notes typically, that'll be very helpful. This is the time when the patient was last known to be neurologically normal. And if the patient's symptoms were noted when they woke up, then the time last known well is when they were last seen well before they went to bed. So that's important to document. Keep the patient NPO. That includes no ice chips or medications because they are at high risk for aspiration. Next, keep the head end of bed elevated 30 degrees. Next, you insert 1 or preferably 2 large bore IVs if the sites are available, preferably the anti-cubital sites, and then maintain the IV patency with normal saline at TKO. If you have time, if you can acquire and document the medical history, that's extremely helpful, especially to note if the patient is taking any anticoagulants or if they have had history of stroke, because these are elements that we take into consideration when we decide if a patient needs a thrombolytic therapy or not. Obtaining weight is extremely helpful. That saves a lot of time in facility because, as you know, the thrombolytic dose of TPA is based on the patient's weight. And if time allows, complete the thrombolytic alteplase therapy guidelines checklist to determine if IV alteplase eligibility exists or not. Now there's another small print of the inclusion-exclusion criteria. This is being updated, and so you will be receiving this soon. But it's something that if you have time, it's very helpful. If not, the receiving facility will go through this as well. So in the end, if the accepting provider or nurse can be notified of the last known well or when they started, results of the neuroassessment, the latest vital signs, anticoagulant status, weight in kilogram if available, blood glucose history, medical history, and then contact information for family is extremely helpful because a lot of times the EMS arrive at the patient and the family is en route and they are not accessible. So it's very helpful to know how we can contact the family the information will be extremely helpful. If you have any questions, you can always call Jenna. She's very helpful as the Lifeline Stroke Director. She's with the American Heart Association Midwest affiliate. And you can also call Christine Brondek. She's also the State Stroke and Cardiac System Coordinator. Both are wonderful gals and very helpful. With that, I will end my webinar and thank you for your time and keep doing a great job that you do of screening, triaging, and transferring those patients, stroke patients, so they can get prompt care at the centers. Thank you.